I'll start off, Jean Benson, been a nurse almost 20 years. I've always worked at Lebanon Hospital. Started out in the emergency department, within a couple of years became trauma coordinator, and I've been in that position forever. And those of you on scene, I'm also a death investigator for Lynn County, been doing that around 14 or 15 years. And yeah, I have an office right next to the ED manager. Any questions? I'm happy to answer them. If you bring a patient in and have a question, come talk to me. If you want to know about a patient you transferred or brought in, please come talk to me. Open door policy. I mentioned it yesterday. I'm not administration. I'm just basically a staff nurse too. So, you know, sometimes administration has more of that responsibility of if they hear about things, they really have to tell it. If I feel it's important enough, I sometimes will have to push it forward. But most of the time, if you just need to talk about something too, I'm there. So I know you guys have a lot of support here, but I know there's a lot of what I think we called yesterday, or what I feel has been a disconnect between EMS and hospitals. And it has nothing to do with the staff, I believe, that's in either of them. I think it has to do with things that are going on in the world and changes that we're having to deal with. And it just happens and happened. So just sort of hoping to change that culture a little bit. So anyway, and
yeah, and I'm Katie Hennig. I am a nurse at Good Sam in Corvallis. I've been a nurse for 18 years, always at Good Sam. I worked 10 years in the ICU as charge nurse most of that time towards the end. And then I switched to trauma nurse coordinator and did that for a couple of years. And then I've been the trauma program manager at Good Sam for the last 5 years. I also manage the Samaritan Corporate Transfer Center for all of Samaritan. And then I also manage another team of nurses, of vascular access nurses, but traumas I love. And I think just if you have, I mean, we're going to go over the exhibits, but when we give you, part of our requirement is to look at quality improvement from every trauma case, whether they were entered in the field or entered at the hospital. And it's never meant to be as a punishment or anything. It's always just identifying opportunities for improvement. And we're looking from a kind of a different perspective. Obviously, I'm not on scene. I've never been a paramedic or EMT. So I don't know that whole scene and everything that goes into it and all the, you know, sometimes surrounding noise that you have. So that's just part of our role, is looking for opportunities for improvement from that perspective. I also work pretty closely with Corvallis Fire, obviously, because they bring us everything. And then we always want to establish that collaboration with EMS, because that's kind of our goal, is to work together, because we're all on the same team, right? From the time you guys get called, dispatch gets called, right? All the way through their throughput. So if you have any questions of cases afterwards, we can go through that too. So.
And this is also learning for us. Yesterday, we learned different protocol things that we weren't aware of, which helps us, because a lot of times we have, oh, well, maybe you could have done this or done that. And we heard yesterday twice, that's not our protocol. Oh, good to know. We didn't know that. I do 100% feedback. If I have a trauma entry that you guys bring in, or if I have a patient you bring in that becomes a trauma entry, I give 100% feedback to Mark. So, but it's usually like a month while I'm doing the charts, because I also do our registry. So again, if you guys want any input, either find me or call me. I don't care. Call me on my regular phone, call the ED and ask for me. And I'm happy to give you feedback. Katie does a great job of getting back with people. I know on the case recent on the young boy, I had actually teamed Katie to get a reply for you guys to see how he was doing.
If there's something immediate, like a concern that we have, then we'll kind of give feedback more immediate to like Mark or something. If it's just nothing, then we'll send a letter kind of at the end. It takes a little bit of time, because I do have a full-time register and 2 full-time nurses. One of my nurses actually is a volunteer for Tangent Fire. And so he gives me a good perspective of protocols and things. Just like the intubated motorcycle helmet sort of thing. He's like, here's actually the protocol. I'm like, great, that's really helpful for us to look at, because we don't have your protocols. So that is beneficial. I feel like I have an insider on my team with those sorts of things that's helpful.
So the main reason we're here, Mark asked if we would come and talk about exhibits a little bit. And then I was in LA and I received a text from Dan that says, do we call in? Do we say red, yellow? What do we do with this new criteria? I'm like, no, just call it in as usual. But it was a good opportunity, I think, to kind of compare the two. When you look at them, they can look a lot different. They're actually very much the same with some very key things that are different with blood pressures and heart rates. And then a few criteria has been taken off of red, put onto yellow. And then we're gonna also go over what our exhibits look like, so you guys know what we do with our exhibits once you guys enter or we enter when they get there. So
Do you want to have them do introductions in time? as you did yesterday?
absolutely, yep. Introductions, if you guys would.
Tell us how long you've been with the department and what your role is. Anything else you want to tell us?
Yeah, Jason Adams, I'm a lieutenant. I've been with the department for 20 years, paid for 8, I think so, paramedic.
I'm Isaac Jordan. I've been with the fire department for about an hour.
Welcome.
Well,
Just a job shop.
Nice.
oh, that's great.
Welcome.
Dylan, met you guys yesterday.
Yeah.
Perfect.
Jake, been here a year, paramedic firefighter.
I'm London. I've been paid for about 6 months now, and I'm at EMT.
I'm Kaden. I've been here about 4 months. I'm just president volunteer.
All right, back row.
I was here yesterday. My name's Mackenzie. I'm a student today.
Okay.
Michael Maynard, I've been with the district 33 years, the fire service 35, almost 36 years, lieutenant.
Kyle Pepper, engineer, paramedic, been with the department for 17, paid for 9.
Caleb, intern for 5 years, 5 months.
Brad McInnes, engineer, been with the department since 2006, mostly as a volunteer, but I got career in 2017.
Perfect. And you guys transfer in from somewhere else?
What do you mean?
Anyone transfer in?
Like
from
work in
somewhere
another
else?
department?
Like were you in a
Before.
different state or another city and then transfer into Lebanon or, okay,
Volunteered on the coast for about 2.5 years.
Okay.
okay.
Cool.
Well, that's interesting. Boy, those resources are quite different, aren't they?
Yes.
Absolutely.
Goose Bay, so that's even more.
Oh.
That is, yes, it is.
I did all my ambient stuff. Vertical Point.
Wow,
Mhm.
yeah. Whew. Boy, that's something, isn't it? Whew. Okay, so, getting started. Oh, it's not hooked up.
Oh, is it turned on?
Maybe not. Oh, that will help.
Okay.
There we go. So, we only put like 7 slides in here. We just sort of ad lib anything we're talking about. If you guys want to interject with questions, please do, but we're gonna just run through the exhibits. As you can see, all of this changed October 15th of this year. New red criteria, yellow criteria. I think they made it red and yellow criteria just more visible for people who are on the scene and those who are more visual and color oriented than kind of the reading orientation. The red criteria is criteria that used to be what we call a mandatory trauma entry. It was like, it meets this criteria, you enter them. The biggest changes they put on here have to do with heart rate and blood pressures. So I know you guys have those in front of you, if you would like to read them. And the wording is just a little bit different. So what I'm showing here is on exhibit 2, the red criteria is the same as the old exhibit, but it used 1 and 2. It was the top 1 and 2 together. And then the yellow criteria on the bottom, which is more of your discretionary entries, are the 3 and the 4s that go anywhere. 1s and 2s go to the highest level of trauma center you can do. 3s and 4s or yellow go to the whatever hospital's the nearest for you. I put these together just for those that are a little more visual. You can see the red criteria exhibit to the new, and I actually compared it to the field criteria, the parts 1 and 2 together. Verbiage is very close to the same, but if you notice on the bottom, mental status changes and vital signs, if you compare them, there's just a lot more detail when it comes to the new red criteria.
And, what was I gonna say? lost my train of thought. Oh, in the context of trauma. So when you look at all those mental status changes and vital signs in the context of trauma, which could be a ground level fall, especially those older adults on blood thinners can have significant injury. Falls from a height, falls from ground level, other #1 injury pattern in Oregon. It's about 50% of our trauma patients are just a fall from height or ground level, so.
So just keep that in mind. I know Katie had mentioned yesterday, if possible, and if you can, really important, just that full set of vital signs and initial GCS. For the most part, you guys are pretty good with that. I have to say, I am one of those. I'm a visual. So for me to go 4 to 5, just do your best to try to get that down and get a good GCS. Especially I know we talked about if you have to do any medications or if they're combative and you have to medicate. It's really good for us to know an actual GCS prior to having to medicate them a little bit. So it just helps, I think, with the assessment of the physicians a little bit.
You'll see when we get to the hospital, that's why it's really important to know that full set of vitals and GCS, because that determines our level of activation. And so the good SAM nurses, if you're going to Corvallis, everyone should be asking for that in your report, because that's triggering how many people they call to that trauma bay.
Yeah, my goal for this year with the staff there is to really try to work with them on the HERE reports. Especially because traumas, if you guys call for a trauma, it would be great. The first thing you say, this is medic 31, I'm calling, I have a trauma system entry.
Agreed.
And give us the criteria that you have. Any trauma system should either be called to the charge nurse, should be called to the charge nurse. Sometimes, of course, we have the 2 HERE systems on 2 separate areas of our emergency department. So if the, charge nurse is busy, they may be off and somebody else will take it. And then nobody really quite knows what it is they need to be doing. So it's just always good to ask for the charge nurse. It's going to take a while to get these things together, but it would be good. And then again, give the criteria. On why you're doing it. Is a ground level fall, active bleeding, crushed, blood pressure, 90-year-old involved in a 45-mile-per-hour crash with bruising on their chest. Matter of fact, we just got that one from Sweet Home. It's sitting in our emergency right now.
One thing, go ahead.
I get just a quick
Yeah, Go
question,
ahead.
Yeah,
and this is probably a preference thing.
Yeah.
Depending on hospital,
absolutely. And different
Yeah.
hospitals. That's why it's good we're
but,
here.
so generally speaking, in my
Mhm.
9 years, if I have a trauma system
Mhm.
or a cath lab or
Mhm.
a stroke,
Yep.
Yes.
Uh-huh.
a lot of times, when I can, depending on cell phone service, I just make a phone call. Do you guys have a preference? You want it over the HERE system? Do you want a phone call? I feel like if I do a phone call, I can give you
I'm
I
gonna.
can give you demographic,
Mhm.
I can give you name, date of birth. and all
A-
that.
absolutely.
Yep, I think that's
Stuff like
fine.
that.
I think that's fine. I would not change what you're doing. focus on
Yeah,
us.
and for us, I mean, it's more of your comfort. Boy, I would say if it was a full activation, try to make that phone call to that charge
Yeah.
nurse and try to get that. And we'll kind of explain a little bit more on why that really matters with us. We actually activate and call a code, trauma overhead.
Yeah.
Especially during the day. At nighttime, you're gonna get the same team. It's the one that's there most of the time. But during the day, it brings a lot more people. And with Good Sam, it's way different than us
Yeah.
because their resources are,
Yeah, one thing I forgot to say yesterday, but on here is tourniquet, if you have an active tourniquet on. So for the hospital, it makes a difference how long that tourniquet's in place. The goal is to take it down and assess bleeding within 2 hours of application. So maybe law enforcement put it on before you got there, but the gold standard is to write on that tourniquet what time it was placed. If you can't do that, or whoever, if, for example, a bystander or law enforcement put it on, if you could ask them the time it was placed, that would be great to give us. You don't have to in HERE report. It's good to know there's a tourniquet in place on HERE report. But when the patient arrives, and you can tell us that time, so we know how fast, do we have a little more time, or were they way up in the woods somewhere? And this has already been on an hour, hour and a half, or do we have a little more time to maybe get them through scanner before we take it down and look at bleeding? That was just one thing.
Yeah. Yeah. So, and then I also have what's called our ED section with all the doctors.
Mhm.
And I'm gonna talk to them a little bit too. I hate to go back to the olden days, or I've done this forever, but boy, we got calls from medics all the time. you guys called us. I work night shift, calling all the time, talking to the doctors. What do you think? You know, what do you want us to do with this? Or asking, or just, and that just doesn't happen anymore. Like I said, we're kind of just separated out. I don't think it really has to do with one thing or another, but just kind of the culture. And then COVID hit, and then everybody sort of hunkered down into their own areas. And we have huge system changes right now, transfers and hospitals and just so many things, I think, that are involved in all of that. So, but I'm going to tell the physicians that, you know, when you guys call, you know, they need to be respectful. And you guys are just calling to get some advice from them. Or if you call to even talk to the charge nurse about it, you know, if you want to, it's your comfort level. Just like nurses, just like you guys, we're dealing with people with all different experience, whether 6 months or 2 years or 20, 30 years. And then not every case is the same, so.
And I think we're all just so much busier, right? You guys have way more calls, probably growing population. Same thing at all our hospitals. We're just busting at the seams. So when I look at the overall census, just from, you know, 5 years ago versus now, it's like 30 more patients in the hospital at Good Sam every day at a minimum. So we're all just busier, right? You're going from one call to the next. So we recognize
Well, I
that.
think probably culturally, it's something that just developed
Yep.
because of the lack of resources at
Sure.
Lebanon a lot of
Correct.
Yep.
times.
Correct.
And a lot of this, you know, we're in a growth spurt people-wise
Yep.
right now.
Yeah,
And we had a pretty core group of people that were experienced, and so we would just not call and bypass a lot because.
Yeah,
we knew we were
absolutely.
going to the
You
right
knew.
facility,
Yeah.
but I think maybe a cultural shift back with the young people, it would be a good idea to start making those calls, even
Yeah.
though you think you might want to go to Corvallis, at least do a courtesy call and make sure that you're not missing something.
yeah,
Kind of bring that culture back around,
yeah, no.
to make sure you're covering
yeah.
all the bases.
Absolutely, because, you know, we deal and even within Samaritan, you know, I mean, it brings up whole new issues for us getting transferred out, you know,
Yeah.
once they're, you know, oh, it's a trauma system entry, they need to go somewhere else. It's easy to say we should just keep them there and it would be nice. Let me tell you, I would love to be able to do that. We are critical access. We have an average of 3.25 days. It's somewhere in there.
Have to stay under
That
4.
we have to stay, yeah, under 4 for sure. That's average for stay. You get little old people and between the resources and social services that they need, they're there for 2 weeks. And we don't want to lose our critical access because it does bring revenue in to Samaritan. So there's times where I know some of these transfers and some of this stuff are like, oh, this is ridiculous. This is something you could keep there. Yeah, we could. But we can't because we're a critical access hospital. So, you know, it does frustrate us too. And I'll be honest with you guys, you know, we wish we could keep some of those. We wish we could get them out of the emergency department and just admit them where they can be cared for. We're in it to do emergency care, not to do bedside nursing. I mean, that's what our nurses went into it for, kind of like with you guys. You're in it to do the paramedic thing, not to do the transfer thing. And I get it. So, you know, we're just trying to let you guys know that there's a lot of rules we have to go by too.
It's not a perfect system.
It is
No.
not a perfect system, and with the growth we've been having, yeah, it has just kind of expanded so many different situations, I think, that we're coming up with. So again, like I said, my goal with the nurses and stuff is to talk to them a little bit more, get them a little bit more proactive, especially the charge nurses, with acceptance of what we have coming in and communication is huge. So I did the same with the yellow criteria, compared the two mechanism of injuries on the top and then EMS judgment and special populations. They're a lot of the same. The one things we talked about yesterday, though, what they did take off of the red criteria was neuro findings, flail chest.
And spinal cord, that got moved.
Yeah, neurospinal cord, flail chest. I thought there was one others that they dropped down, and they made it a yellow and not a red. So, and I mean, that's kind of nice. I mean,
Oh, red might still be, it's for hospital that suspected spinal cord or CMS.
suspected
things.
spinal cord.
I mean, I think it's always hard with vehicle telemetry consistent with severe injury. I think that's your judgment on that one probably, since that's very subjective. But the nice thing is fall of height greater than 10 feet for all ages instead of 20-foot fall, like, is a heck of a fall.
Yeah, vehicles
And an
have
older
changed
and
so
older.
much over the years too. It's like,
Absolutely.
you know, the cars now.
Yeah.
just-
Yeah.
They're made to destroy around themselves.
Right.
Yeah.
So, you know, when I was 30 years ago, I mean,
Right.
if it was a bad wreck, the car was twisted up, somebody was hurt. I mean, we had one, the last shift, the truck was ripped in half just about from hitting that house and they were both just fine.
Yep.
You know, it's
I
like,
love those compartment shots. It's
Yeah.
just that one
Yeah.
compartment where that
Yeah.
person sits and the rest of that
Yeah.
vehicle
Yeah.
is just, you know, one thing I teach in the seatbelt class too, and I'm sure you guys probably know this, is that crash tests done on those vehicles are done at about 35 miles per hour. And I'm gonna take just a wild shot in the dark that probably 50 to 60% of crashes that take place are at a higher rate of 30 than 35 miles per hour. So they're doing the test to say how well and effectively the vehicle does, but it's not a high rate of speed when they're crashing them into, of course, it is a brick wall.
Yeah.
It is something that
It is a big
doesn't
wall.
get,
Yes,
but yeah, just that, you know, the testing isn't done at really high rate of speed. So.
Yeah, and they took out the miles per hour for a bicycle or pedestrian or motorcycle ATV crash, and they just kind of said separated from transport vehicle with significant impact. So I feel that's kind of subjective. also.
Yeah, and it lets it go to you guys and your experience and what you think, so, and we were just talking yesterday, somebody was talking about a case that Dan took. You guys had called him and said, hey, should we bring this in? And he goes, oh yeah, it was an ankle dislocation, we can relocate it, it'll be just fine, and then later on, you guys found out you had to transfer it. And you're like, what? You know, trying to get him to the right hospital. It was because they had a little abrasion, and that abrasion ended up being an open fracture. Those have to be washed out, they go to the OR, orthopedic sees those, so, yeah, you know, we can't foresee everything, we'll do our best, but we just can't.
Sometimes it just looks like a little pinprick, but if it actually
abrasion,
communicates
little
to
road rash.
that joint or bone, wherever it may be, then it,
Yeah, the flesh gets
Maybe.
pulled back a tiny bit and then it gets covered back up and blood coagulates and it all just sits in there and it just doesn't look that bad. So any questions on the criterias? So, this here is our criteria. So you guys are pre-arrival. Ours is more of the, what kind of a team do we call in? So the red criteria, turns into what we call a full activation. If we have a trauma surgeon on call, that surgeon has to be there within 30 minutes. At Good Samaritan, it's a 15-minute. So there's different time restraints that pertain to the different levels of trauma hospitals you have. And between that and the ED doctor and the CT people and our nursing supervisor, that's kind of our team. We don't have a lot. Now, Katie?
I mean, you know, if you've ever brought a patient that ended up as a full trauma, but we have a whole slew because we have surgical residents, general surgery residents. So we have 12 right now. So they spend 5 years with us, but they're in training to become a trauma surgeon or general surgeon. So we have usually a junior resident, a senior resident, a surgeon. The junior and senior residents are in-house 24/7, but the attending surgeon has 15 minutes to respond. So if you give us a little heads up, like 10 minutes out, that's helpful, especially if it's in the middle of the night, because our trauma surgeons are not required to be in-house. But then you have the ED nurse, a recorder. For one of these fulls, we hold an operating room and we get blood from the blood bank ready to go at the bedside, just 2 units of red cells. So with that patient is hemorrhaging, and then we can rapidly transfuse that blood. And we also have the CT scanner on hold, but we have all those, also the ER nurse, ED physician, lab, radiology, all those. X-ray comes over usually we do a chest and pelvis before we take them to the CT scanner, as long as they're stable. But all of those people, so giving us a heads up warning of 10 minutes is helpful to know.
And for us, that's one of the reasons why they go on trauma divert. It's because our surgeon is in the operating room. We have one operating room. We have one anesthesia on call. We have, you know, kind of one OR crew that's going to be available. So when we go on divert because of that, it's because we don't have those resources to offer somebody in case something does happen. Modifieds are a little bit different, but boy, for those full activations, there may be some changes coming down. And we'll see where those come, and if those do come down, I'll come and do more education if Mark will have me back or have Katie and I back to talk a little bit about how that might look. But so currently that's why we do go on divert if our surgeon is busy.
Good Sam very rarely goes on trauma diversion because we recognize that's a huge impact to the community. So for us to go on trauma divert, it's usually after hours, and because we only have 2 OR teams at that time, we have 3 anesthesiologists and 2 trauma surgeons always on call, but if all those resources are used, then potentially we could.
Any questions?
But we try to always minimize that and go on for the shortest period of time. As long as our surgeon's gonna be available within an hour, then we won't go on diversion.
And this is a look at, of course, the modified team, emergency physician, emergency nurse, lab and radiology. We really don't do lab. We do have a lab tech come down if it's a full activation. If it's not a full, we really don't, because if we start our IVs, we draw the blood type of a thing, you know, and if it's just a modified, we can usually get the blood down to them. Whereas the fulls, we have them come down, they draw the blood, they take it back, they end up doing all of that. Plus, they may have to call in more resources in the middle of the night.
Good Sam still has a bigger team on modifieds, even the
Yeah.
ED doc, we still pull a vascular access nurse, an ED nurse, a recorder, CT imaging, just because we have more resources available to come and help and work those patients up quick.
And this is just a picture of our old one. So these 2 are the newer, those 2 are the older. They go side by side, just like you guys. Red criteria is full, yellow is the modified team that we call in, or your discretionary. So while it looks like a lot had changed, there's not tons, I think, that really has changed.
I will tell you a good Sam, if you say I'm bringing in a red criteria trauma, they're gonna have no clue. So just that trauma system entry, what the mechanism is, and that full set of vitals in GCS, because GCS determines that part of the trigger as to what level. So that's why it's important to the nurses.
Yeah, and this is something that Katie put out to some of the trauma people that, the trauma nurses and things. On exhibit 2, she talks about, red criteria, age 65 and older with systolic blood pressure less than 110 or heart rate greater than the systolic pressure should be transported to a higher level of care available within the geographic area. So, and then with exhibit 3s, which are our full trauma activation criteria, it includes, of course, the combined systolic blood pressure in adult patients less than 90 or hypotension in children 0 to 9. You can read that. And then the following have been removed: full trauma activation criteria added to modified chest wall instability, flail chest, 2 or more long bone, that's what we forgot, fractures and suspected spinal cord injury have all moved to yellow criteria or discretionary instead of full.
So at any time, blood pressure less than 90, which I think is tricky if you give some medication and it drops their blood pressure, especially, or the older adult that's on beta blockers and, you know, ACE inhibitors and everything, maybe they're a heart failure patient and then they have a traumatic mechanism, maybe ground level fall. They're kind of maybe already teetering because that's their goal, is to have their blood pressure 90 to 100. So it's just a conversation to have. I recognize we're going to probably overactivate and at Good Sam and activate more than we need to because we err on the side of caution, but it's always easier to send people away, I say, than try and get people when your patient's crashing. Just like, you know, on scene, right? Welcome as many hands as possible. It's real hard when you only have 2 hands and you have 4 patients. So.
Yeah. And I know I mentioned it yesterday too. We always mention multiple patients. Recently, I think we had 3 that came from Lebanon. And one of them, I did talk with Mark. I don't very often get a hold of Mark within a few days and say, hey, this probably should have been an entry, guys. I think he was 75 or 80 years old. He was pretty banged up. He had a lot of stuff wrong with him, but he was walking, you know what I mean? We all get those. They were walking, they were talking, they looked really good.
Mm-hmm.
They do till they don't. And then there was 2 other people. One of the issues that we do have is that we have 1 CT scanner. And we have an emergency department room that is also full of people who need CTs, whether it's a head CT or an abdominal CT. If we have a full activation come in, we call it overhead. And that means our CT person gets that person out of the scanner as quick as they can and safely. And they wait for us to bring them our trauma activation. Modifieds are a little bit different. the doctors will come in, they'll get things assessed. We will bump them to the head also, but if we have 3 of them waiting, we have to decide, okay, who should go first, who shouldn't. And I'll be honest, I don't have x-ray vision. We always can't tell which one is the worst injured either. So it could be hour and a half, 2 hours before that third person gets into the CT scanner. And it really goes outside of that critical hour window that, we're all trying to get to recognize the type of injuries that they have and start the treatment that they need, because there is that golden hour that happens. So for us, that's one of the reasons. It's not just that we don't want free traumas. Let me tell you, we got some nurses who are like, yeah, bring them on, bring them in. But we don't have the resources to get them into CT scanners. And I know years ago, we had one, she was, I think, 6 or 9 months old. I don't remember. One of 4 that came in. It was help from Sweet Home, but we got 4 of them and they flighted a few of them. That child waited 3.5 hours for a CT scan. And, I thought, everything turned out and that's great, but it is a good learning opportunity, because if that would have been my child, I would have wanted my child to be in that scanner within 30 minutes to an hour of having that happen. Because there was a death of a same car occupant. So, just something to think about, with resources. We'll work as quick as we can, just like you. Sometimes you don't have enough hands or enough resources and you just have to prioritize the best you can. So that's what we have to do too. So it's not that we don't want to take them. It's just that we really shouldn't be taking them because it's not best for the patient all the time.
I'll never turn away trauma patients, bring them all. But part of what we learned yesterday is I didn't realize if you have a trauma system entry, you have to drive code 3. So we didn't
Even
know
Mom,
that.
yeah, didn't know that.
Even if it's kind of like a ground level fall, suspected head injury,
Do you guys
older
call
adult
it
on
in code
thinners.
3 or do you call in, I'm coming in code 1 with the trauma and you come lights and sirens?
If we're coming for 3,
I don't
No,
think anyone-
but can you do lights and sirens coming code 1, like, oh, I'm coming code 1 with the trauma patient?
Well, code 1 means no license.
no license.
No license.
Okay, so that it actually just goes back and forth.
Yeah.
Yeah, I mean, there's tons of stuff. I don't
Really our
know.
discretion too. I mean, if
Okay.
we feel like we need to go faster.
Absolutely.
Yeah.
Just assume.
Yeah.
Yeah, we don't care how you drive and we won't ever critique that, I will say, in our
Yeah.
feedback is, the road conditions and the patient in front of you. We kind of look like, was there airway breathing circulation, IV access if indicated, the appropriate size, IO if IO was used, and spinal preventions, spinal precautions.
Under
Big things.
some circumstances, it's our discretion under,
Mhm.
if it's trauma system entry, stroke or.
Yeah.
Or,
Mhm.
STEMI,
Yeah,
we
absolutely.
have
Yep.
to go code 3.
Yep.
Yeah.
And then sometimes the paramedic is just like, I don't like this patient back in my ambulance.
Yeah,
You know,
Well,
like, and,
yeah.
like, I'm not sure how long they're gonna be okay.
Yeah, no,
Sure.
we,
Yep.
So
it's that 7th sense. No,
Yep, yep.
we have it too. It's like, I don't know what it is. I can't pinpoint it, but something's not right here. I don't want to be the one to find out. So absolutely.
My nurse came to me last Friday and he's like, I think it's gonna be a massive transfusion full trauma day. And I'm like, I don't know. By 8:30, we had a massive transfusion in the OR and I think we got 4 traumas before like 2 o'clock. I'm like, that's enough of you. So that,
Yeah.
Is there any people or recent traumas that you guys have that you guys want updates on or? anything?
That guy last year,
Yeah.
yeah. What day
Last
was it?
year.
Tuesday, so
Days
Saturday.
ago.
Yeah, we took him over to Good Sam.
Vehicle versus pit.
Vehicle versus bicycle. He broke a hole through the windshield with his head. And then obviously.
was he young, like
No,
20?
No, he's probably
56, I think. Yeah, femur and.
I'll have to look. I'll get back to you.
Fit.
Okay,
like 6, 7 o'clock, 7 o'clock at night.
Okay.
Through the windshield, boy, that's good.
Yeah.
impact.
He went up and over. and
was he wearing a helmet?
No,
Of course.
no, it's not. Methamphetamine fuel.
I was gonna say, was there alcohol on board?
No, meth.
Just meth. Yeah, there you go. Then they get
In the
superhuman.
middle of the road, didn't see him, no brakes, smacked him.
Yeah, so
Mhm.
I live on Berlin Road. Oh, there's a lot of traffic out there and it's drug traffic.
Yeah.
Black hoodies, black bikes, constantly riding back and forth. Yeah, up and around the corner by those 2 areas that you go in where all the beehives are and everything. Yeah, so much traffic and someone's gonna get seriously hit out there.
Find out for you.
So,
I guess I have a question. So a couple different times I've brought femur patients in with traction pulled. And on each one, I've gotten that traction device back within like 2 minutes of that patient getting in there. Do you guys just like visualizing it without traction, or I guess more like why is it not your guys' flow to like scan and see what's going on first? Like what's your guys' mindset on traction devices when patients are brought in?
That happened on that day. We had a traction device back, his foot was blue by the
Mhm.
time we got there, and we left with our traction.
They didn't put him back into one?
I don't.
Well,
know.
they can't scan through
Right, they can't scan.
them, so they've gotta come
Was there
off.
med?
Was there what?
Now,
Was
we
there
use the disposable.
I'll
ones.
ask.
And I've actually, I think years ago, I gave them to
Right in
each of the departments.
Or do you have none?
Yeah, so no, ours don't. So we had the problem is we would transfer people out with them.
Say that one more time.
If they're metal.
Oh, I just said, because it's metal, they can't scan through, so they take them off.
Okay.
We use disposable that you scan through. You
I
scan
think
and x-ray through.
if we do have a femur fracture, if we take that off, we're gonna place pins right after scanning. Ortho's gonna place pins and traction typically. So it is temporary, and I get traction really helps with femur fractures.
Especially pain,
Um,
circulation.
Yeah.
Yeah.
So the one thing that's excluded on here is ground level fall hip fractures, isolated.
Yeah.
Ground level hip fractures.
We don't have to enter those.
We don't
Those
enter
are
those.
excluded out of the.
Or if you just have the little person that has a ground level fall and suspected hip fracture, that's still excluded.
Yeah.
Just,
In 2017, we actually did, that's back when Bobby was still there.
oh.
We did a quarter of adding in hip fractures, like any of them. That's all we were putting in, were hip fractures,
I know.
ground level fall hip fractures, ground level fall hip fractures.
Yeah, it'd probably be 400 or 500 more patients for me.
Yeah, it
a
is.
year.
Oh, and you were right about San Diego too. Well, I saw the one where it said they had 71 patients
Oh,
and we had like 34 or 40, but then I looked back and we only had 6 less than they did it on other times. So
Oh.
I'm not sure why there was a lot more on that one.
Okay.
But yeah, no,
okay.
yeah, I saw exactly what you were talking about yesterday. So yeah, and if you guys want to try a disposable, I'm happy to give them to you, but we use them because, usually some of those people will end up going up to Portland somewhere. We never get them back.
What do they cost?
Hundreds of dollars for the metal
Well, I
ones.
don't-
Oh, for the disposable?
Oh, the disposable?
Sure, they're not super expensive and
Just, you don't use a ton of them, it would make, I mean, we spend more time tracking those things down and never get half of it.
Yeah.
absolutely. So I do know years ago, we used to have Life Flight. There was a guy that worked for Life Flight, and he would go up there and they have what they called it a graveyard room that they would go into, and it had nothing but hairs and saggers in it and backboards and stuff from all the medics and all the other departments that everybody had left in there.
They
So
used
he
to
would
ship-
try
used
to,
to ship it back to us.
did they?
Yeah,
Yeah,
they would bag them up and mail them and send them.
Uh-huh.
back.
that's nice. Yeah, they don't
But
anymore.
they-
No, yeah, and so those get expensive. That's why we went to the disposables.
Well, we went to the slice machines or slice.
Yeah.
And they're a lot smaller,
Uh-huh.
compact, but I mean,
Yeah.
no more than they are, a disposable one would be.
I'll bring a couple by for you
yeah,
guys if you
yeah.
guys want to just check it out.
Yeah.
They're not perfect, but boy, for a good couple hours, they work well and we
Yeah,
can
they're
take
not
them right
long,
in
they're
to get them
short.
scanned.
Yeah, they're
And
short
then,
fixed, I mean, for us.
Yeah, I
Absolutely.
think that's good if you're going to Lebanon. At Good Sam, I think we strip everything off our patients right away. And then if we have a concern, then we're placing pins in that ER pretty quickly by ortho.
Gotcha.
So it's a difference of just
Resources than what we have, yeah. Yeah, because for us, it's like, we don't like to take them off and, take that off and then put another one on. It causes pain and it causes problem, then it takes time. So,
Mhm.
we just stick them into that and then we can just do everything with them. And leave it on for transfer too, unless it's gonna be delayed transfer. And then we have a new process that I came up with. It's a box traction system that I came up with that we'll probably use maybe once every 3 or 4 years, but we have it if we need it. It's the same thing as what we're talking about, but it's something that goes off of the bed and it holds it at pound. So it just pulls it out and drops
Yeah.
off the bed. So it's more
Mhm.
comfortable and it won't cause the breakdown that what we're talking about will cause if you leave it on for prolonged periods of time. So, yeah, we just have them in a regular bed and then it puts traction on the leg.
And we do box traction without pins sometimes on those.
Yeah.
Especially older adults, if they can get away with just box traction and weights, we'll put like 15, 20 pounds on it.
Yeah.
Yeah, it's just, you can't do that in the back of the ambulance, we
Yeah.
have weights swinging around
Yeah.
and whatnot.
And it took us about a year to come up with a way to do it with us, but we do have a way. it's not pretty, but we have it, you know, and it works for the patient. So, and it's amazing pain control for those femur fractures. It really is. To get those things reduced in, you know, somewhat alignment, it just stops such a
Yeah,
process.
he was still in pain, but we got a lot of relief once they finally got it straightened out.
Mhm.
Yeah, good.
Just a general question about, you guys were talking a little bit about, like full spinal protection, backboard
Mhm.
collars.
Mhm.
Are you guys seeing it, are you guys seeing any kind of what you would note as like overuse, underuse,
I think I've seen a couple recently, where maybe it wasn't quite as secure as it could have been. Like we had a helmeted intubated PEDS patient and he was in one piece of plastic tape, but one piece of plastic tape is not very much. So he got intubated through that, which was fine.
Yeah.
We took the helmet off as soon as he got here, but when I happened to be in the ER that day when he arrived, and he might have been in alignment in the back of the ambulance, but when he got to us, he looked like this. And that might have just been transferring from
Bed
the
to
stretcher
bed.
to the bed, but that is important too. We have to do that. So just making sure that however they are, that they stay in that good alignment. He did have a spinal cord injury too, but it was thankfully at the thoracic level, not cervical.
Yeah, and those helmets are so big and heavy. They have that tendency to kind
Yeah.
of
So as
lull over
Right.
or
Absolutely.
something.
Right, as long as they can stay, I think your protocol says as long as they can stay in spinal precautions, you can intubate through
Yes.
them.
No, I just asked because.
Yeah.
Over the years, there's been like a lot of contrary studies that have come out with, you know, the negative effects of boarding certain people.
Yeah,
certain
correct.
Absolutely.
populations,
Correct,
stuff
yeah,
like that.
absolutely.
And so we try to make a conscientious effort of
Yeah.
like, you know, but I'm just curious on your end, are you seeing like drastic decrease where people should be or,
Yeah.
you
So,
know,
so there's one, from summertime that was co-treated with Tangent, and I actually went to Tangent. I don't know if any of you were on that call, but it was Tangent, Lubra, and 7 Mile Lane. It was the T-bone. Patient was ejected. And that patient that was ejected, I think the initial thought was maybe you guys were first on scene after Tangent as a transporting agency. Albany also came. That patient was just a scoop and run, but she showed up to Albany ED without an IV, without spinal precautions, without an airway, with a GCS of 3. So we couldn't do anything to prepare that patient for scan or surgery or anything until we had done all those things. She also ended up with bilateral chest tubes and whatnot, but we needed to stabilize her to then get her to Good Sam because she ended up decompensating en route and going to Albany. So my recommendation would be, I get scene time is critical, but make sure you stabilize that patient at best to your ability
With what you have
with
at that
what you
time.
have. So
Absolutely.
some sort of airway to keep her, maybe not intubating, but maybe just keeping an airway. And it depends on the resources. Do you
Yeah.
have 2 people in the back of the ambulance or 1? I get it. That's
yeah.
different. But putting her in spinal precautions and giving her an airway would have been huge for that patient because she had a significant head injury. She did proceed to brain death, but it took a couple hours at Albany to get her stabilized, which time is brain with that. If, maybe we could have decompressed her soon because she was essentially proceeding to brain death by the time she got to Corvallis. I had one I reviewed with another agency from last summer that it was the T-bone into a tree. GCS was 3, but not intubated on scene. They were bagging the patient, going to Good Sam, and then cardiac arrest. So now what do? And then that patient never got any ACLS meds because they were like, oh, it's a trauma. And I'm like, no, we still do ACLS. You're in VFib. You got to give some epi. So just things I think we can sometimes get down one track very easily and forget the whole picture. Same thing on healthcare. We're not perfect by any
Nurses,
means. Nurses,
absolutely.
physicians, we can always kind of think, oh, we think it's this and it's something else. We just had that on a neuro patient. We were convinced it was a medical cause and it was actually his spinal cord injury that was missed by the radiologist.
And
So-
I talked about the ground level
Mhm.
fall in the bathroom. It was a couple of years ago. And I used it kind of more for the nurses to talk to them a little bit because you get down this rabbit hole. And you
Mhm.
guys get that, somebody showed up on scene, said, oh, he's a 50-year-old, he drinks all the time, he drinks every day, he's a bad alcoholic, constantly falling, he's passing out. This is his normal, but we just can't wake him up. So we called the paramedics or the medics. So you guys get out there. It was either Sweet Home or Lebanon. And so we start down that rabbit hole that he's just a drunk. Get him in the ambulance, get him to us, we get him there, start doing some neuro checks on him and, the Babinski is done and we think, crap, he's got a head injury. And it was bad. He died. He ended up dying, but he'd fallen at the toilet, whether he was vomiting at that time or not, whatever happened, he fell, hit his head and he laid there and he died. No C-collar, no, there wasn't anything. And, with ones like that, if they pass out and they're still passed out, I would just throw a collar on them. That's just me. I'm like, if they come in, even walk in for triage and they discuss something like that, throw a collar on. We'll toss the collar as soon as it's cleared. We can't clear them. Our doctor has to clear them, so.
I think alcohol is really hard because it fogs your
Very.
neuro assessment, right? But if you have any sort of traumatic mechanism, maybe a bump on the head, and you can tell they're intoxicated, for us at Good Sam, they're probably gonna have a head injury of those alcoholics, likely, maybe not. We had one that, was a neighboring agency and it was an unwitnessed fall off of maybe 4 feet onto gravel and that patient was belligerent and so it was just hard to get her into the ambulance and she wasn't a field entry, although she qualified. And then the ER realized once she got there, oh, this is a full trauma and activated. But we're a little bit behind the game, activated a full trauma, got her to scan. And by the time she had gotten a scan, she had herniated. But we did proceed to organ donation on her, but her blood alcohol was 450. She was a professional. So, but I think it's just, then they're fully anticoagulated. I think her INR was like 2.4 also. So those are really challenging patients, especially in the back of your ambulance, I imagine, trying to just get them to the hospital safely.
Two things I do when I used to just practice out as an RN, any person that's an alcoholic, they become that person who's on blood thinners for me. So they're not on thinners, but let me tell you, being a bad alcoholic like that, it is like having somebody on blood thinners. So I treat them as such, as if they're on thinners, because that is more likely to happen with them.
To Kyle's point, you're not seeing a trend that we're not missing. I mean,
No.
it's just
No, I've seen a good trend of not doing backboards, which has been great. We had a big problem for a couple of years, way back when I started.
it's more than a couple of years.
And
We got it in every.
well, absolutely. And then we left
Yeah.
them on the boards
Yeah,
in the emergency rooms. So they never came off. And I've really seen a great cultural change. And I love that part of it. For the most part, even with cervical collars, you guys are doing a pretty fair job. There's always a couple, hindsight is always 20/20.
Sure.
But for the most part, it's been good.
Okay.
And I think unless they complain of some sort of pain,
Yeah.
if they're complaining of back pain or lumbar pain, thoracic, then put them on the backboard for sure.
Sure.
But if they're not complaining of any of that, then, we're gonna collar everybody if they're trauma injury in the ED at Good Sam. We're gonna collar everybody and we're gonna pan
Yeah.
scan head to pelvis.
Yeah.
And that's us too. And that's what I talked about, the resources. We just don't do a quick assessment and do x-rays. We pan
Nope.
scan, we do head to pelvis CT.
Yeah.
It is the gold standard. If you've had any type of trauma, that's what we do.
Yeah.
So, you can do a chest x-ray and find no fractures, and we can do a chest CT and find fibrin fractures.
Yep, absolutely.
So that's why we just end up,
Yeah, we've been kind of leaning into it for years now, where like
Mhm.
a lot of people that
Mhm.
used to just get like, you're getting a full deal because we're doing it. And we're
Yeah.
here.
Yeah.
And now it's like, well, let's throw a collar on them.
Yep.
And-
Yeah.
And maybe
Yeah.
move them to
Yep.
the cot with a scoop
Yep.
stretcher.
Yeah.
And then we'll
Yep.
remove that scoop stretcher
Yep.
underneath them because it's a little bit more
Absolutely.
comfortable.
We
can make it more comfortable on our cot than we can on
Yeah.
on a board.
Absolutely.
we just had a scoop stretcher last week, I think, that came to our ED and it was great. There was nothing wrong with it. It's fine. Spinal precautions with, cervical collar.
And I love to see, tried to put cervical collar, patient won't tolerate it, took it off, perfect, you're covered. If they keep scrapping it off and pulling it off and, there's just nothing you can do with that, but you have it documented. I try to look at it from that standpoint. I did have one chart I sent back, pretty sure it was from Lebanon, where somebody had put down that they had cleared the C-spine on scene.
Oh,
I'm
yeah.
like, so FYI, you can't do that. If this goes to court, you're in big trouble. I can't even clear a C-spine. So just watch that verbiage there, especially some of the younger ones too. I understand you've palpated, you don't think there's an injury, and that's perfect. That's what you're supposed to do. But I would watch saying you cleared it, assess C-spine, something, just don't put you cleared it.
Yeah.
Because that, on a stand, they will, especially if something ended up happening.
And we can't clear patients until, if they're altered, till that's cleared.
Yeah.
We're not able to clear them.
Alcohol used to be an exception on here. We used to have alcohol in our trauma. You remember that? So if they were drunk, you couldn't ask them a question and clear anything.
Mhm.
They were injured until proven otherwise if they were that intoxicated. So.
Yeah.
We used to intubate them and then just pan scan them and extubate.
Have you heard some of our patients now?
Yeah, and we've had patients come in, in the back of an ambulance that we got 3 from that I-5 fog incident a few years ago. And I had a guy just happened to jump in the back of the ambulance. He had like an abrasion on his head and he had some gauze on his head. And the resident was like, hey, I'm gonna send him for a head and neck. I'm like, are you gonna put a collar on him then? Well, I'm like, well, if you're gonna scan his neck, you better put him in a collar. And sure enough, he was the one patient out of the 3 that we had that had a cervical fracture, and he was walkie-talking, didn't complain of really any neck pain, but a little bit, and he had some whiplash, and sure enough, he got discharged that day in a cervical collar, but still.
Yeah.
It's just, he had no complaints.
And anything different that the hospital can do or
Mhm.
that we can do
Yes.
to help you guys? Come on, hit us.
Well, I'm sure you probably, this is your second day, so I'm probably sure you heard last week. The biggest thing that I see and have seen over the time that I've been here is that I understand from the hospital's perspective, when we bring something in and things aren't done the way they think they should be done, it's not the time to dress down the crews.
Absolutely.
Correct.
If there's an issue, address it through you or Mark or whatever, but we just had last shift, we took a guy in that it was just a suprapubic catheter, but hadn't been draining, and then mom was concerned, kid's got a long-term health issue. We went to Lebanon. They diverted us because they have surgical.
Mhm.
So he made a phone call, he made a hear report, got diverted, went to Albany and got dressed down in the ER in Albany because they can take care of that in Lebanon. So, and
No,
it happens often.
It's
with
not the
us.
place for it.
It's not the place
Nope.
for it. And
Correct.
I've even been dressed down by a supervisor at the hospital in Corvallis that ended up being a pretty big deal in front of the entire staff and had people
Wrong.
come out and
Yeah,
apologize to
that's-
me, right? It's like, that's not the time for our people, and a lot of our people are
Correct.
moving young and making a learning process for them, not.
Absolutely.
a
Correct.
detriment. I see it too much.
Okay.
Okay.
I really, and our guys will come back and go, oh, they welcomed us in Corvallis this time, it's like, we have certain criteria we have to meet, and as long as we've done our part by calling our medical control.
Yep.
And we've taken that
Yep.
person to the appropriate facility, those conversations should never be had
Correct.
in front of a patient.
Correct.
Or in front of our people.
Absolutely.
And especially from up here.
Yeah.
If
Yeah.
they'd like to take it a little bit farther for an inappropriate transfer or
Yeah.
whatever,
Sure.
you can do that.
Yeah.
But hindsight is so easy. And
Yeah.
it's so easy for people to say, well, you should have taken this somewhere else, or you should have done that. And I'm sorry. I know it's
Mhm.
not something that I did, but I'm sorry you feel that way, because I know when our nurses get it, it's not a good feeling.
And it goes
it's,
both ways.
it's not right.
It
Right.
goes both ways. We get
Absolutely.
pissed off because
Absolutely.
of things that happened at the hospital,
Yeah.
we have no control over.
Right.
It's
Your
just
wait
an
times or
understanding
whatever,
of
yeah.
How things work, but if I had a suggestion, like your charge nurses,
Absolutely.
have them come write us.
I would absolutely love that.
Because those-
We used to have that program, and about 15 years ago, I know it kind of stopped. I think that's a fabulous idea, and I will actually bring that up and talk to them
Because
about
they're
it.
the ones that are making,
Mhm.
they're the ones we're interacting with on those calls.
Yeah,
And understanding that sometimes when we bring patients in, we've got an experienced medic that brings somebody in because of, and does certain things because they have the intuition. and-
Yeah, right.
And then they get dressed down for it. not okay.
It's not
But
okay.
I think having those charge nurses who are the ones that are making those decisions, understanding why we are doing the things that we are doing in the field, because our world's not perfect.
Yeah.
You know, and we're going into chaos most of the time in those types of incidents. And sure, we miss things, but we're doing it off of knowledge and intuition
Yeah.
sometimes.
Mhm.
And having them have a good understanding of what goes on in the field and not complaining because we didn't get that IV. Well, the guy's covered in mud and he's cold, he's
Right.
been laying in the
Yeah.
ditch for hours.
Right.
We're not gonna get an
Yep.
IV in that 5-minute transport, right?
Yep.
Having them have that understanding, I think will go a long ways. And maybe if they see their people dressing down our people because of things, they'll understand, hey, that's not right. This is, you know, they do things. I think it would just be a good idea.
No, I think
Thank
that
you.
would be a great idea. I know when I first started, I did the ride-alongs and it was completely eye-opening.
Well,
Because, you know, you guys package them up and bring them to us and they don't have to go into those situations. They don't have to go into the homes that you guys go into or be on scene where you guys have to, or in the dead of the night when it's 40 degrees outside and it's pouring down rain, you know, with like black ice on the road. And,
Mhm.
you know, there's just a lot they don't have to do and they just don't. So absolutely, I
Mhm.
will definitely have that conversation and, I'll talk to administration, see if we can get that going for you. I think that would be amazing. I'd like to see better communication with everybody.
Yeah.
And like Katie said, when it started, when we do a review, it's more of like, hey, maybe this could have been different. It's not to say you were wrong with it. It's just like, you know, maybe take a look or maybe something can be changed or maybe somebody just needs to be reminded.
Mhm.
I have to be reminded of things too and consider it a learning experience, but nobody should ever be called down.
No, and I think your system's probably like our system. We have such a revolving door of people, right?
Yeah,
And we have a lot of leadership kind of changes right now
Yeah,
at Good
and
Sam,
young
so,
people to be put into positions.
absolutely.
Yeah.
Ready.
Yeah,
And maybe not have any kind of, like you said, you have a person at Tangent Fire that you get to work with, but if you didn't have that, you wouldn't have a lot of perspective that you do.
exactly. I
Because-
didn't about that helmet, because I was
Yeah.
like, hey, they intubated through the helmet, blah, 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 blah. And he's like, look, here's their protocol. I'm like, thank you, but,
yeah, didn't know.
you know,
And there's things that may not get done for us because, like I said, we're out in that muddy ditch or whatever, and
absolutely.
having an understanding what it takes to do our job and you guys, we bring you into a somewhat sterile environment, you know,
Right.
for them to work on. It's
And you brought up a good point of that scene time to hospital time is really important. How much are you gonna do at the scene if you're 2 minutes from the hospital versus 45 minutes from the hospital?
Yeah.
That's a big difference.
Yeah, we had the guy last shift that they were wanting to do all these things and we knew we were going to Corvallis. It's like, these are things we can do on the road. Let's do those on the road.
Yeah.
Let's get them in the
Yeah.
back of the ambulance and get going. But if we're going 11 and we know we're probably going to get a little bit
Right.
more done because we don't have time roadways to get it done.
Yeah.
Anyway.
All right. Well, if you guys have anything else, questions?
Yeah. And if you have examples of that where you got drilled at Corvallis, please send it to me.
We'll do.
Email it to me or
Yeah,
stop
send it to
in.
me, whether it's a trauma patient or any other patient.
I do know I have one charge that is, they're like, I don't even know why we get any trauma. We don't do trauma here and this is stupid. I'm like, because we're here. That's why. And we do trauma.
Well,
We do everything and that's why. And, you know, getting rid of that culture will help also.
and even if it says you should go to the highest level trauma system, if that patient's unstable and needs an emergent airway, you have the right to stop at the closest hospital. Our area trauma advisory board supports that in our plan. You stop at Albany, get that airway or whatever. I mean, we had that gunshot wound, right? Went to Lebanon, had surgery and then transferred to Corvallis.
I had one I'm taking to the doctor's 34 minutes. I don't know if it was you or Sweet Home that brought it, got it to us, got an airway, IV, out within 34 minutes and taken to Good Sam. We don't even have, according to the laws, we don't even have to scan that person to tell you what the problem is. If we know they're that sick enough, we can help with airway lines and we can just ship them out. And that's a culture too that I need to talk with our doctors about. While it's great that you go down that rabbit hole and want to find out what's wrong with them, but are we really doing the best with the patient? If they are really a full activation and you know, they're probably going to need a lot of those more resources, get them intubated and get them where they need to go first. Instead of sitting there trying to.
Although I have a funny story about that. We had one from the coast a while ago and they were calling our neurosurgeon because the ER doc's like, I have a motorcycle crash, full helmet, but closed head injury. He needs to come to you right now. And he's like, well, did you scan him? Because I'm the neurosurgeon. I can't do anything without a scan of the head. And so you're delaying. Please scan the head before you ship him to us. So we accepted the patient, scanned the head, and there was
Fine.
no injury at all. We discharged them from their ED. So
Yeah.
if they can, I mean, granted, that
The-
was
the-
a
the-
different,
yeah,
that was
this
just
guy-
an
this guy was
isolated,
pretty
stable
banged up.
patient,
He was messed up.
stable patient, but,
So,
um,
and it's also talking about the cases too, because it allows us to maybe think of what could we have done differently, you know?
mhm. So like if a trauma patient comes to Lebanon, Jean will review that initial,
Always.
and then she'll review like EMS and her ED, and then I will review her ED and our.
Yeah.
Um,
And if you take it straight there, she
Hospital.
just gets everything. So, and I'm happy to do either, but like I said, our full activations they're very minimal, but we do try to get everybody on board and get the patient the best care we can get them, so. Anything else?
any other questions about, it doesn't have to be a trauma patient.
I haven't. I don't know if I have.
Oh, nothing like being on the
Oh,
spot.
so you did say when we don't say like yellow or red.
Correct.
Yeah, just say trauma system entry and why you're entering them.
Give the criteria.
Give the criteria. Fall.
So
height.
even like the little old lady that falls, she's on blood thinners. Do you want us to put that in then?
If you enter the person, say, yeah, put a trauma system entry, ground level fall,
And you want us to put bands on and everything?
put a band on them, correct? Yep. We do have a few that aren't, that you guys don't. And other hospitals work a little differently. As long as we're notified they're on thinners at once a fall, most of the time we will try to make them ahead of everyone else and get them CT'd really quickly. You know, mentation, there's just a lot of different things that play into it. If we entered every ground level fall, head bonk, possible head bonk
Mhm.
on thinners, it's just like that femur fracture, we would be inundated with trauma patients that really didn't need to be there.
But if they have a mental status change
Absolutely.
from their baseline,
Mhm.
then that's probably a consideration. You know, did they lose consciousness and their GCS is 13, 14 now versus they're feeling fine. They just want to get checked out because they're on thinners and their GCS is 15. I wouldn't say enter those. But if they have a decline in mentation, err on the side of
Absolutely.
caution.
And as you go through your career, you're just gonna start learning. There's things that are gonna happen that will change how you practice and what you do. I think we've all had a few of those cases that are
Mhm.
like, oh,
For sure.
I'm gonna change what I do now.
We all
Or
make
I do
this,
something
right?
different.
Like,
It's like I'm on alcohol, I'm gonna consider you're on blood thinners. That's just where I've always gone. But there's just those cases.
and we all make mistakes. We think about cases, we're like, yeah, if I was to go back and do that again, I would probably do that different.
Would it help if we just go through, like, when we're calling in those trauma system entries, or, just hit the buzzwords on the sheet?
Yeah, you don't have to say, blah, 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 just, yeah, putting a trauma system entry in, based on, you know, high rate of speed, elderly, you know, whatever, with hypotension, or just something like that, you know, full set of vitals would be great. If you don't want to give a long hair report, just if you could have them when you get there for us. I mean, that's something I know as a hospital I'm working on with the staff, is putting your guys' information into the trauma here report. We've been slacking on that a little bit, and it's very important for the doctors to come back and see, because there's times you're like, oh, I didn't know they got pain meds in the field. If you would have been there during the report, if you would have heard the report, or if you would have looked back in the chart, but sometimes it just doesn't quite get in there. So, those are things I'm kind of looking at from the nursing
Yep.
standpoint.
And I go to our ED section, which is our ED physician meeting every month too. And if they miss any patients, then we give them feedback as to why also. So, and then as an area trauma advisory board, we're looking as the whole general region, which is from the coast, you know, past Sweet Home, and includes in Salem. So we're looking at, hey, it looks like they met criteria in the field and they weren't entered. We're just looking to pull data for that, for all agencies. We're not honing in on any one agency. We're just kind of overall looking, because a lot of it can be kind of subjective with that vehicle telemetry or
Wow.
significant impact. Kind of challenging.
So, and I don't know if we mentioned it, we have what's called an area trauma advisory board. And so Oregon is made up of 9 regions. Each region is its own, what's called ATAB. And within that ATAB, so we have Salem, Santiam, Silverton, Dallas, McMinnville, the coastal hospitals, all of Samaritan. through here. And we all just meet and we discuss, we have criteria to discuss certain cases or interesting cases.
So if you wanna join, we meet quarterly, but they're actually
You do it
changing.
your
it.
own night.
What's that?
You do it on your own night, that's why I.
Well, it's twice, so it's during the daytime
Oh, that's
in
Yeah,
January
We do
and
do it during the
July.
day.
And then it is in the evening, so, I mean, you do have to submit some forms to apply,
If
to
you want
be
to,
on
send
it,
send
because
it
there's
to me if you're
confidential.
interested, and I'll send them to
Who
Christine.
from the organization do you want representing that?
I would say whoever, we would just like to have some input from you
Mhm.
guys.
Mhm.
Because currently, like I said, we only get what, Jefferson?
Jefferson,
On on a-
Corvallis fires
all the
kind of
time.
intermittently.
But that's
present.
2 out of, oh my gosh, we have Sweet Home Lebanon within ours, and, a lot of those regions have multiple ambulance areas. and
Life Flight you typically is on there, Life Flight's typically.
So, and then, they can be kind of boring too, but like, we, and I know you heard this yesterday, but when some of this criteria came up, especially the blood pressures and the heart rates and stuff, Good Samaritan and all of our ATAB put together a few people to represent up at the state, and different regions did too, that we didn't agree with it. We didn't agree with some of these changes that came out, and we were really trying to push to not have them or have something better defined. And, it didn't happen, but we sure tried to fight it a little bit. But the state didn't accept that, and they put in what they wanted. So yeah, Mark, if you're interested, let me know. I can
Well,
do-
Aaron actually.
Perfect,
yesterday,
Aaron,
she
sure,
was in the-
absolutely,
Yeah, that's great.
absolutely, yeah.
Everybody.
And because, there's ones during the day that are via like Teams. So, I mean,
And-
you guys could all hang around and.
We do some case reviews and education. Dr. Surfin, my trauma medical director, did ocular trauma just recently as education, and then Jefferson Fire did that huge presentation. Also, when they've done another one where the I-5, where the rest stop is, when
Yeah, that
that
rest area one, remember that one? It was
workers got
huge.
hit and there was like 6 deaths on scene.
The semi,
The
they had a bunch of
semi-
workers in it.
It was an impaired semi-truck driver.
Oh.
And they were parked
Oh.
off the side of the road.
Yeah.
Anyway, they did that whole presentation. Jefferson always does a great job.
Yeah.
But we like your input. But what I was gonna say is the state is changing from just an area trauma advisory board to more time-sensitive emergency management. So it's going to include stroke and STEMI also. So it's gonna be interesting how our trauma advisory board or our local board goes, but it's gonna be the same for the next year. And then it will include some others, so we're not quite sure how that will work out. But we would love to have EMS.
Let's have Erin join us if she wants to,
Mhm.
even on just those particular days for a
Mhm.
couple hours or something, so. Any other questions?
Thank you for your time, we appreciate it.
Thanks, guys.